Svetlana, you're welcome to start, I think.
Okay, thanks, Guy. Good afternoon and good morning, and hello to all colleagues who are joining us today. My name is Svetlana Axelrod. I'm a director of the Global NCD platform in the WHO headquarters. And my very welcome hello to all my WHO colleagues and my team who have this webinar today, and also to all the participants who are joining us for these 6 webinars that we have as a series that we call NCD Voices in the Decade of Action. So I'm really very pleased to say that once again, we have ensured that we pass the microphone to those who have lived experience to share their experience and perspectives in regard to a critical gap in the current NCD responses. And as we have mentioned before, we must ensure no individuals or communities left behind as we are to build back from COVID-19 and to continue to work together towards our global goals. So the global coordination mechanism which is under the global NCD platform that I'm leading, will continue to offer a platform for the voices to provide their inspirations and experience so that we can create effective NCD response that leave no one behind. And I want to use this opportunity and to thank everybody who was participating last week in the WHO informal consultations on people living with NCDs. We had more than 130 participants from all over the world, and it was really a very fruitful discussion, and it gave us a new opportunity of our collaboration. And we are very pleased that Dr. Tedros was also had time and provide us a video message. And it is very important that it is also under his patronage, and he's looking for the people who are living in densities. So let me maybe say a couple of words finally that now we have this last seminar, as I said, the 6th seminar, but we will continue on the next 2021, and I hope that everything will be successful for us as it was now. So thank you very much for my WHO colleagues who will speak today later. And now I would like to pass to my colleague, Dr. Guy Phones, the head of the Global Coordination Mechanism, who will introduce our discussion today and our speakers. Over to you, Guy. Thank you.
Thank you, Svetlana. In motivation, inspirational words as we launch this 6th webinar. And obviously a good day, good morning, good afternoon to all those who are joining. But before we jump into the discussion, the active discussion with our guests, let me provide you with a bit of background on what brings us here today. As we've heard already in very much in the last months, the unprecedented COVID-19 pandemic and its response measures have brought governments and citizens to a standstill due to devastating social, economic, and development consequences. The centrality of the right to health as a fundamental pillar across all development dimensions has been made dramatically evident. What brings us today is anchored in the dramatic fact that the deadly interplay between the COVID-19 pandemic and the NCD epidemic has exposed the chronic vulnerability of and underinvestment in health systems response to NCDs and mental health conditions. And people living with NCDs and those requiring rehabilitation services have by far suffered most from the collision of these forces. The UN Decade of Action reminds us that the foundations of the Sustainable Development Goals originate from a leave no one behind philosophy. It underscores the urgency of engaging lived experiences in a meaningful and sustained manner to understand what it means to leave no one behind and who is being left behind, in order to co-create cross-cutting, demand-driven, and contextual responses to deliver on all SDGs. The WHO informal consultation on people living with NCDs held just this week, and which Svetlana mentioned recently just now, concluded that we must understand the fullness of lived experiences and how the rich and diverse contexts, insights, and expertise that these bring can and should be empowered, enabled, and represented across all of our efforts to build back better. Bearing this in mind, the NCD Voices in the Decade of Action webinar series aims to pass the microphone to individuals or communities that are often left behind because there are no mechanisms in place for them to be heard. These voices are not brought to the center stage where they can shape solutions from global to local. As we now set forth to design a comprehensive and sustainable roadmap to build back better from the impact of COVID-19, we must recognize the urgency of understanding how to address the devastating gaps exposed by the pandemic. Now more than ever, we are accountable to individuals, communities, and society. One of those huge gaps is the dramatic neglect of action to address the unmet rehabilitation needs of people living with NCDs. The COVID-19 pandemic further exposed and contributed to the limited access to rehabilitation, with a dramatic finding that over 60% of countries responding to a WHO survey reported partial to complete disruption of rehabilitation services during the pandemic. To unpackage these considerations, we have the pleasure of welcoming you to the latest iteration of this webinar series on realizing rehabilitation and healthcare for NCDs. We have invited 6 distinguished speakers to highlight the why, the where, and the how we can build that better through a rehabilitation lens. We will hear from Helena Davies and Stephen Watiti, both direct stakeholder trustees and lived experience advocates from the worldwide Hospice Palliative Care Alliance. Also from Bente Mikkelsen, director for the WHO Department on NCDs. Theo, Institute of Health Metrics and Evaluation from the University of Washington. Alarcos, Cieza, unit head of sensory functions, disability and rehabilitation department of NCDs at WHO. Jessica Crofts-Lawrence, head of policy and advocacy, International Agency for the Prevention of Blindness. A great presentation of speakers, which we'll hear soon, and who will provide expertise, knowledge, and insights from their respective areas across NCDs, rehabilitation, and importantly, lived experience. We very much welcome you all to also add to the discussion to the Q&A function. Please submit your questions as we have a discussion at the end with some of the speakers on trying to address those questions. So make sure you post them on the Q&A and we will pick them up from there. Finally, we are recording this webinar, and both the slides, all slides, and the video will be made available to the group through the WHO's Knowledge Action Portal on NCDs. Now, let's start the discussion. And our first speakers, I'm extremely pleased to be joined by Dr. Helena Davies and Dr. Stephen Watiti, as mentioned, who will bring in lived experience perspectives from the UK and Uganda. Their perspectives are crucial as we aim to walk the talk and embed the ethos of nothing for us without us across NCD policies, programs, and services. Helena and Stephen, the floor is yours.
Thank you. And thank you so much for inviting me to talk today about user perspectives on rehabilitation. Rehabilitation is about the restoration of optimal function after illness or disability. I'm a person living with extensive and highly complex NCDs, with a long and complicated course to my illness, consisting of a decade where I had a chronic illness and was on medication, but was actually able to work as a hospital paediatrician and function pretty well. I then had a major flare in 2007 with inflammatory nerve and muscle damage when I was in hospital for 3 months, since when my functioning has been significantly compromised, including being dependent on an electric wheelchair. I had to take ill health retirement at that point. My illness course since then has been characterised by periods of relative stability, interspersed with exacerbations, a number of them life-threatening, with breast cancer thrown in for good measure. Life has also been complicated by numerous musculoskeletal complications, including bilateral ruptured Achilles, multiple fractures, and degenerative arthritis, particularly in my hands. Rehabilitation of all types and intensities, even including knitting for my hands, has made a huge difference to my life. It's also important to realise that rehab is about carers as well as patients. It shares responsibility for recovery, provides structure for their input, and provides hope of improvement. My first specific rehab intervention was at the beginning of my illness when I returned to work after being off sick. What I needed to enable me to work optimally was assessed by a rehabilitation team and included providing me with specialist seating and a desk, and importantly, a nominated spot in the car park close to the entrance. I can't tell you how jealous everyone else was of that. Exemplary rehab was then provided following my return home after my 3-month hospital admission. I benefited from a fantastic community-based intervention, which provided me with 12 weeks, where once a week, a neurophysio and an occupational therapist came and did a full assessment, and from this planned the next week's input, which consisted of a physio or OT assistant coming into my home 4 times a day to do rehab with me, 7 days a week. It was completely transformative in terms of my functioning. As well as the physical benefit it provided, it made me feel valued as a person and helped me come to terms with being a wheelchair user. It also ensured I was provided with aids, such as grabbers to pick things up, specialist cutlery, an appropriate mattress, and many other aids to daily living. Physiotherapy and occupational therapy are components of most rehabilitation services, but I think it's also worth spending a little bit of time sharing with you some of the less obvious rehabilitation that has been of benefit to me. Improved functioning and effective rehabilitation is dependent on being motivated to engage in rehabilitation. To that end, hope is very important. I was sent to a neuro-rehabilitation centre in another city for a second opinion. Although there were specific physical benefits to this second opinion, what actually meant most to me personally was being told that I could continue to improve in a range of different ways for a number of years because of something called neuroplasticity, the possibility of one part of the brain taking on the functions that have been lost in another part, a phenomenon only fairly recently recognised at that time, and an enormous source of hope and motivation for me. Managing pain is also an essential component of rehabilitation. I have been fortunate enough to receive over 10 years of palliative care, which has expertly managed my pain in a way that enables me to engage optimally in rehabilitation. This has included acupuncture, which I haven't been able to have during COVID and have certainly missed, and in the past, hypnotherapy. Another really important component of my pain management has been mindfulness. In addition to its benefit in pain management, it has been of huge benefit in terms of psychological rehabilitation, particularly learning to focus on the moment, not in a hedonistic way, but in a way that means I avoid the what ifs all the time. I have also had formal psychotherapy through the palliative care service, helping me to restore my identity and psychological well-being. Another very important aspect of rehabilitation for me has been gardening and being with nature, and there is an increasing body of evidence to support this as part of rehabilitation and improving well-being, both mental and physical. In Japan, for example, there is a scheme where a week in nature, usually a forest setting, is prescribed for this purpose, and social prescriptions for gardening and nature are becoming increasingly common in the UK. At a personal level, I feel so strongly about the benefits of this that I've established a healing garden charity in my own 1-acre garden to make this sort of nature-based rehab available to the local community. However, I am conscious I am one of the lucky ones. I can actually talk to you about the range of rehabilitation I have had and its benefits. Many individuals living with NCDs have little or no access to rehabilitation, as we've already heard, and this has been exacerbated by COVID. We need to work hard if we are to realise the Rehabilitation 2030 call for action. Thank you. Over to you, Stephen.
Thank you very much, my friend and colleague, Helena. My name, as you've been told, is Stephen Watiti. I'm a Ugandan physician, but I'm also a person living with HIV, which I've lived with for about over 30 years. And at the height of my problems, I had cancer. I've suffered from cancer, Kaposa coma, and TB. But I developed meningitis about 20 years ago, cryptococcal meningitis, which was a very debilitating condition because I had severe headache. And because of the fact that my immune system was failing, I was referred for palliative care, which did a lot of good for me. I did improve, but I had to learn almost doing things all over again. For example, I couldn't write. I remember an experience when I could not even sign on a check to get my money from the bank. I, however, gained from physiotherapy offered by Mildme Uganda, which was a center at which I was getting the treatment. They gave me this and taught me through occupational therapy how to start to live with an incurable disease. At the moment, I don't have any non-communicable condition and I'm fairly healthy. But I have very many people who come to me because of my work who have HIV, but have NCDs. Some of them have strokes. Some of my patients have gone blind. And these need a lot of support through rehabilitation to be able to live, because they are not dying because of the efficacy of the medicine, ARVs, that are giving them hope. And this is when I decided to use my experience, not first as a doctor, but also as a person who has had a chance to gain from rehabilitation, to advocate for this very crucial service in universal health coverage, because it's possible that people can be helped, but they need this, and it is not universal health coverage unless it includes rehabilitative services that respond to the needs of people as they grow, especially we people living with HIV now who are aging with the disease. I'm one of them because at the moment I'm about 65, 67 rather, and I've lived with HIV for over 35 years. I can imagine that there are many, and I see many of my colleagues, my patients, who need rehabilitation, and the services are not there. Now, COVID-19 and the lockdown that accompanied it did disrupt many of these services. For example, people cannot access physiotherapy, people cannot access their health centers where they can have these services provided. But on the other hand, they're also not so much available, especially in my part of the world. So I think it's important that people like me, and I've been encouraged by my colleague, Helena, do use our experiences, but they need to be helped. For example, to be taught how to communicate. Sometimes sharing from personal experience is quite draining and can make people get tired. And sometimes people get depressed. And yet, people tend to listen to people, like when you listen to my sister, listening to her, explaining what she has gone through. Her voice is so authentic. So I really do believe that if we are to achieve universal health coverage, we must do a lot of advocacy, but also demand creation, because many people are out there with rehabilitative needs. But sometimes, even if they're available, they may not be able to ask for them or to access them. Of course, they're made worse by COVID-19 and the disruption that has caused. But I think we need to use voices of people with experience like myself and my colleague to advocate for these services in the first place, that there are budgets for them in our governments and all the other bodies responsible for providing them. But also on the other hand, speak people who need them, that they ought to use them. And if they are not there, to demand for them. Because as I've alluded to, it is not universal unless it has all components of of UHC. I thank you. Over to you.
Thank you so much, Helena and Stephen. This is so poignant. This really comes back to that phrase I used at the beginning, which is really to understand the fullness of lived experience. In a sense, the layers and layers and perspectives and matrix of what makes a lived experience, and how those layers and perspectives and really expertise on navigating health systems and navigating daily daily conditions and visions and ambitions, provides so much to understanding how to address some of these gaps. I think it'll be very useful going forward in the discussion, and hopefully you can come back with additional perspectives and insights. But now it's my pleasure to move on and pass the mic to Bente Mikkelsen, Director of the Department of NCDs at WHO, and she'll give us her perspective from the technical department side on addressing the essential rehabilitation in essential health services. Bente, the mic is yours.
Thank you very much for giving me the mic, Guy. And first of all, I will also thank very much Dr. Helena Davies and also Dr. Stephen Watiti. And I think my new wish for the new year is that you could speak to the Global Fund and really tell them why they need to include also NCD into their new strategy, and not only the single diseases like HIV/AIDS, tuberculosis, and malaria. I think your example is exactly that we have to go the whole way, as was very much what Helena was saying, and also the comorbidities and the complexity that rehabilitation has to address. So thank you very, very much for this. It was very clear, and also I would emphasize on the positive impact that rehabilitation actually has on people's life. You are proof of that. You are at work and you're really doing a fantastic job despite your diseases. So this proves over and over again what's unfortunately still a misconception about rehabilitation, that this is luxury services for those who can afford it, for the few, and only those for severe long-time disability, which is not true. I think we all know that disability is part of the whole pathway, and the earlier we can put rehabilitation into the treatment, the better outcome we very often will have on the functionalities. So as Dr. Axelrod and also Guy Fons were talking about, we did recently in May a rapid assessment survey on the impact of COVID pandemic and service delivery. And we unfortunately found that 60% of the countries responded that rehabilitation services has been disrupted by COVID-19. So these disruptions reflect the extreme fragility of rehabilitation services in many countries. So it's been like an X-ray, and it shows us that we need to act on this. We are at a critical junction, so we need to build back better, as Svetlana Axelrod said, and we need to really improve health systems from prevention, early diagnosis, treatment, through rehabilitation and palliation, which was also mentioned by Helena. The 2nd of December this year, we had a historical moment where WHO, IHME, and also the Lancet Commission, not the Commission, the Lancet, launched the data from the first study that provides global estimates of the need of rehabilitation. I'm sure Alarcos will speak to this, but it is truly dramatic, and it is the first time. So it shows that 2.4 billion people, 1/3 of the world's population, who live with a health condition that could benefit from rehabilitation. So obviously we need to transform the challenge of COVID-19 and the new data into an opportunity when we redesign our health system, especially for rehabilitation. So today, based on the two very personal experiences, we heard that most essential action that need to be done, namely to recognize that rehabilitation is an essential health services and that we need to include this into the universal health coverage. We will hear during the webinar on other essential actions from our team, both from HIME, Theo, and also from Dr. Alarcos Cieza, which is the lead of rehabilitation and disability and sensory impairment in the NCD department. So Theo will concentrate on the global need for rehabilitation and why rehabilitation needs to be recognized as an important public health agenda, and that essential health services is needed into UHC and we cannot ignore. And Alarcos will concentrate on the need for the advocacy for rehabilitation, also emphasize with why we need so desperately your voices. WHO cannot do it alone. We need the engagement and collaboration of all of you. So without further ado, I will give back the floor to Guy to introduce our next speaker, Theo Voss. Thank you so much, Guy, for organizing this important event.
No, thank you, Bente. Your leadership, not only with rehabilitation, but across the NCD agenda has been visionary. Thanks so much. And actually, I would actually give the floor now to Alarcos. I think she's, as you've mentioned, Bente, as Alarcos is head of the sensory functions, disability and rehabilitation department and unit in WHO. She's best placed to really connect the upcoming speakers, Theo Voss and herself, Alarcos herself, and Jessica Crofts. So Alarcos, please just feel free to engage and connect these speakers and presentations. Thanks. You're muted, Alarcos.
So thank you so much, Guy. Also thank you to Helena and Bente. And it is a great pleasure actually for me to introduce our next speaker, Professor Theo Voss, who is Professor for Health Metrics Science at the Institute of Health Metrics and Evaluation at the University of Washington. We have been collaborating with Theo and his team for the last 2 years, indeed, to put forward this study on the global estimates for rehabilitation. And it is not only that the results speak for itself. I can say that at the personal level, it has been a tremendous pleasure, adventure over the last 2 years. And we look forward still to the future. But for now, Theo, about the adventure so far and what we have produced, please.
Okay, thanks, Alarcos. Your sound quality was a little bad, but I understand that you want me to take the floor now. It was about a year and a half ago that Alarcos approached me and said, we have this meeting, ministerial meeting on rehabilitation in a couple of weeks. Can you do something useful for us with information from the global burden of disease? And so I then engaged one of our young bright ones, Kate Causey, who in a very short time was able to pull together estimates that are available in the global burden of disease, but not easily accessible and not in a way that people can download with all the website and the download functions that we have. So let me explain to you how we came to make these numbers, what choices have we made, and then at the end, I'll give you a little glimpse of a bespoke visualization tool that will go live in another month. But I've got the beginning of it in a mock-up that I can show you. So let me share my screen. Oh, I'm told that the host has disabled share screen. So
we will disable you shortly. Apologies for that. We will enable you in a second.
It should now be working, Theo. Please, can you try again?
Yeah, it is. Let me make that fill the screen. Okay. So what we set out to do and have built on since that meeting a year and a half ago was to try and make a best estimate of the number of people who would stand to benefit from rehabilitation based on Global Burden of Disease 2019 data. We've quantified this over the time series from 1990 to 2019 in detail by age and sex, We've aggregated up to WHO regions, but the data are also available for each of 204 countries for which we make estimates. We show estimates by particular diseases and conditions that contribute to the need for rehabilitation. And when we aggregate to this, particularly when we aggregate to this overall number of 2.4 billion people, we take into account that one person can be afflicted by more than one of the conditions, and so we don't double count the same person. We've made use of what in global burden of disease jargon are called sequela, or the consequences of diseases and injuries. And each sequela is mutually exclusive of any of the other estimates of health loss. In consultation with Alarcos, we made the following choices of diseases that we would include. So quite a few musculoskeletal disorders. Among the cardiovascular diseases, acute myocardial infarction and heart failure. Then COPD, neoplasms, but I'll explain in the next slide what choices we made there. Then sensory impairments, hearing loss, vision loss, quite a range of neurological disorders, and including an estimate for cerebral palsy, which is not an entity that we had quantified previously in the global burden of disease, but we managed to aggregate up all the motor impairment consequences of neonatal disorders and infectious diseases. We chose to include 3 mental disorders: schizophrenia, developmental intellectual disability, and autism spectrum disorders. Now, some of these choices you can dispute, but you know, this is what is reflected in the numbers. Now, we decided to not include any asymptomatic health states, also to not include health states with mild motor impairment, borderline intellectual disability, lesser severity of hearing loss, mild vision loss, and minor injuries. For cancers, we included the initial phase when people are diagnosed and get their primary therapy. In addition, we added in the longer-term consequences of people with colon and rectum cancer who have a stoma, people with larynx cancer who had their larynx removed, and the proportion of breast cancer patients who had undergone a mastectomy. And when you look at the numbers, you see here the 2.4 billion overall number of people who at some point during the course of their illness would stand to benefit from rehabilitation. And you can see the very large contribution by people with musculoskeletal disorders, followed by, in terms of the numbers, by sensory impairments, neurological disorders, the 3 mental disorders, COPD, and then less so the cardiovascular diseases and neoplasms that we included. But I've also included our estimates of years lived with disability. So that's a severity weighted prevalence. And in the last column, I give the average severity, what we call a disability weight. And that indicates that neurological disorders and the COPD and the mental disorders that we've included have relatively higher severity on average than the other categories of conditions. And while these reflect that weighting by this average severity. This is the detail at a global level by age and sex. On the left, you see the prevalence in 1990. On the right, the prevalence in 2019. And you can clearly see an effect of aging, where the peak has shifted from relatively young adulthood and in quite a flat sort of shape of the curve across young and middle-aged adults to a much later peak at around age 50 or 55. Also indicating that the need for rehabilitation is relatively evenly distributed between men and women. This is another take of this overall need for rehabilitation. On the left expressed as prevalence, and on the right as years of life lived with disability in age standardized rates. And there you can see also what I already highlighted is this relative severity, where the top brown part of the bar for neurological disorders is a much larger contribution if you express it in years of life lived with disability because of the greater average severity. It also shows this distribution by the WHO regions, and the thing to note there is that the need is ubiquitous. It's not as if it is concentrated in one part of the world. A relatively similar age standardized rates for the need of rehabilitation, but the contribution of different disorders varies depending on where you are. So just to sum this up, we hope that this detailed information on the need with all its detail by age, by sex, the type of condition, and by country or aggregates of countries is a useful tool for those who are planning rehabilitation services, but also those who want to advocate for greater attention to be given to rehabilitation. I mentioned it once, but I just want to stress that we're not saying that 2.4 billion people are in need of rehabilitation every day. It is the way we've estimated this is at some point during the course of an illness, we made a judgment that rehabilitation would be recommended. And in some cases, it's a one-off intervention, for quite a large number of people included with uncorrected refractive error. It may be as easy as just providing glasses after a measurement of the refractive error. But it could stretch to much longer term rehabilitative care, as for instance would be the case for people with a spinal cord injury, blindness, or cerebral palsy. Now, this is a starting point in setting the tone for what the overall need is. It would be really helpful, but as I indicate, quite a large endeavor to complement this by looking at what we know about the effectiveness of various rehabilitation interventions, and then to quantify what is the potential in years lived with disability, in Davies, to prevent ongoing burden. At this time, it's hard not to say anything about COVID-19. We're actually currently trying to do a first quantification also of the non-fatal consequences of corona disease. And there's some rather alarming reports of substantial organ damage, in the lungs, in the brain, in the heart, that can affect people after having recovered from the initial phase of the disease. And so we're trying to quantify in what proportion of cases does this occur, in what proportion of cases does this already lead to symptoms, in what proportion of the cases can we expect a tail of COVID in coming years and decades of ensuing disabilities because of these consequences. Now, lastly, as I indicated, so we're building a bespoke visualization tool for these rehabilitation need figures. It won't be ready until middle of next month, but I can give you a sneak preview. So let me switch between screens and let me see, I've lost where I stop share, and then I share again, and then I'm hoping that you're now seeing a map of the world. Is that correct?
We are, thanks.
Okay, so this is what the tool will look like. The only thing that's functional is the map function so far, but there will be an ability to make bar charts, to examine trends over time. It allows for specific groups of conditions, or among groups of conditions, individual disorders to be selected. When there's a choice to toggle between looking at prevalent cases and years lived with disability, in numbers and in rate space. You can choose ages, very specific age groups, all the way up to 95 plus, and quite a lot of detail in the early neonatal and under 5 age groups. And then the age standardized option, if you want in rate space to look at figures that are standardized to a standard population that we use routinely in the global burden of disease. You can choose sex, males, females, both sexes, and you can slide over time and find the relevant view for each year. There's even a nice metric here where now that we have the bar going from 1990 to 2019, if I click on that, it will now show by how much have the estimates changed in proportions over the period from 1990 to 2019. And then with this bar, you can see that the largest upward shift was in Burundi, followed by Syria, Haiti, and Haiti has a lot to do with the earthquake in 2010, Syria for other well-known reasons. Burundi, I don't quite know, but I suspect it also has to do with longer-term consequences of ongoing conflict situation. So this is not yet live. Our developers made a special mock-up so that I could show this to you today, but in another month, you should be able to use the tool, and there will also be a function that whatever view you're looking at, you can download all the data that is behind it. And so it gives you maximum flexibility to work with the data. And if you have very large data requirements, then Alarcos has every detail, and she can't find it in the data we've passed on, then we're happy to help out. Thank you.
Thank you, Theo, and I extremely appreciate spending today also the time with us. I mentioned at the beginning when you could not hear me well that it has been an excellent collaboration with IHIME, with you and your team, and that this work will change the conversation of rehabilitation around the world. So that is also the reason, as Bente says at the beginning, we consider the last week launch an historic moment for rehabilitation. And of course, we look forward to further collaboration on this respect. And I see already that there are some questions in the question and answer box, but let's proceed at this point and then come back with the discussion. And I would like to now come to a brief presentation on rehabilitation. And, you know, as you can see, I hope that you can see.
We can see Alarcos, yes.
Despite of all the problems that I'm having with my computer.
Now it dropped.
Now it drops, but it will come back. It's my second computer. Today it seems really like something does not want to work from my end.
Yeah, it's back. We can see it.
So, and as you see, you don't see a title of my presentation, no? Because when preparing for today, I thought, you know, actually what I want really to talk about is about two mysteries that I have been confronted with since I came to WHO to work on rehabilitation. Let's start with the first one, with the first mystery. And it has to do very much with what we have been hearing today already. And starting with these fantastic experiences from Helena and Stephen, and thank you for sharing those experiences, because they have been telling us the benefits that they have experienced at the personal level from rehabilitation, and really the fundamental impact that rehabilitation has had in their health, because we know that rehabilitation is key for optimizing healthy life expectancy. It is key for reducing the experience of disability, as both Helen and Stephen were telling us, and optimizing their functioning associated to their conditions. Is effective for improving clinical outcomes. We know that one of the benefits of rehabilitation, especially when it's provided at acute care, is really the improvement of the long-term outcomes of other interventions like chirurgical interventions. We also know that rehabilitation has many cost-effective interventions included in its scope. And as we have heard, that rehabilitation makes a huge difference in people's life. And again, I want to thank Helena and Stephen for telling us about this difference that rehabilitation has had in their lives. We have also heard from Theo. 2.4 billion people today have a health condition that benefits from rehabilitation. And even the comment that Theo portrayed before, of course, we cannot say that we are not saying that everyone needs rehabilitation, or that all these people need rehabilitation in this time point, but we don't even consider that is an underestimation, because of course, for many conditions, rehabilitation is a long periods of time and even lifelong. So there is a huge need for rehabilitation. And here is where this mystery comes in. Despite of all of this, the demand for rehabilitation is extremely low everywhere in every country. And most importantly, and also to the desperation of many of us, the provision and the delivery and the supply of rehabilitation is also extremely low. We assume, and we have been assuming here at WHO, of course, there are two factors that are extremely related to this supply and this demand. We have been talking about what is the need related to, and of course it is related to the increased need of the number of people living with the non-communicable diseases, also the aging population. But in terms of the low supply and the low demand, we of course related to the low capacity in countries to provide rehabilitation services. In some countries, we have reports that there is 2-3 rehabilitation professionals working in the whole country or some regions. And the low demand is related to the low awareness of all these benefits for rehabilitation, and also in many cases of the low awareness of the huge need for rehabilitation, but especially the benefits for the low awareness of the benefits for rehabilitation. And this picture is what has determined the strategy of WHO, of the rehabilitation program of WHO. And we talk of a dual strategy, and a strategy to turn that around, this picture around, to increase the demand, and also to increase the delivery and the supply for rehabilitation. And if we concentrate, and for that reason, actually, with this dual strategy in mind, it was for that we created this global initiative, Rehabilitation 2030, that has as objective to unify under a common narrative all stakeholders of rehabilitation, working towards a common goal, the common goal of equity for rehabilitation, that everyone who needs rehabilitation receive the quality services that are needed. And if we have a little bit of pause and reflect on the work that we are doing on increased capacity, we are really developing a number of technical tools to work with our member states, with countries, with ministries of health, and stakeholders in countries. One of these tools is this Rehabilitation in Health System, a guide for action to accompany member states and ministries of health through a process of assessment, of strategic planning, implementation of an strategic plan, and monitoring and evaluation. Other tool is, for example, the development of a package of rehab interventions or rehabilitation interventions, so that countries know what are the interventions that need to be integrated in universal health coverage and how to budget also for those interventions. And we are currently working in 22 countries together and very close together with ministries of health, and we have the request of another over 20 countries that are waiting for us to, with our tools, to support so that the rehabilitation services can be integrated, developed, and integrated into universal health coverage. And actually, my message in terms of the increasing capacity is that from our point of view, when we work in countries, that is the easy part. We tell to countries, and countries are moving along, and that is also reflected through the high number of requests that we have. They are moving along with our narrative of recognizing the breadth of rehabilitation. That was extremely well portrayed by Theo. It is about addressing musculoskeletal condition. It is about addressing cardiovascular diseases. It is about addressing vision and hearing impairment, and so on and so forth. We also countries are coming along, and now this work with IHIME will contribute even more to that, to portray the increased need for rehabilitation also at country level. And as Bente mentioned also at the beginning, we are telling countries, we have been boxing in rehabilitation in a small box saying, these are only service for the few. And we are telling countries they need to more and more move forward to integrating rehabilitation at primary and secondary level, not only deliver at tertiary level, because actually at primary healthcare level is where you can reach the people who need rehabilitation most, and most of people who need rehabilitation. And of course, that rehabilitation needs to be integrated into the continuum of care and as part of universal health coverage. And again, countries are moving along, and still a tremendous amount of work to do, but we are optimistic. The point that I want to make today is that actually the most difficult part, and where really the second mystery of rehabilitation is about increasing the demand and the awareness of rehabilitation. Because if we reflect on it, there is no advocacy of users for rehabilitation at all. And actually, that is the reason why we found, and we are really thankful of this collaboration with the global mechanism, coordinating mechanism of NCDs, and with our colleagues, also Guy Fons, and with ADG Espelana, because we really realized that we need to gain, all of you, we need to gain the NCDs voices to address the second mystery and ask you, what does WHO needs to do so that we gain your voices to advocate for rehabilitation? And we hope that this will be the focus of the discussion at the end, after we have heard from our next speaker, Jessica Crofts-Lawrence, who is the head of policy and advocacy at the International Agency for the Prevention of Blindness. It is the International Agency for the Prevention of Blindness, a great collaborator also of our department over many years, and we work very intensively with them and really learning a lot from them in terms of advocacy. And Jessica will shed some light on the advantages for moving an agenda forward of hearing from the voices of those who has experiences for the services. So Jessica, the floor is yours. Thank you.
Thank you, Alarcos, and thank you, Guy, for inviting me today. Good morning, good afternoon, everyone. As Alarcos said, I'm Jessica. I'm from the International Agency for the Prevention of Blindness, or IAPB for short, and we're the overarching global alliance for the eye care sector. For those of you who don't know us, our network unites more than 150 organisations, from NGOs, corporates, eye hospitals, academic and research institutions, and professional bodies in more than 100 countries. And together we work for a world where everyone has universal access to eye care. Advocacy is at the core of IAPB, and we coordinate all global eye health advocacy efforts, providing the sector voice at the World Health Organization and the United Nations, and leading many major global campaigns such as World Sight Day. I think there are many parallels which can be made between eye health and the rehabilitation movement. Of course, it goes without saying that rehabilitation is a fundamental component of integrated people-centered eye care. But from an advocacy perspective, we have much in common. I think there's a general understanding amongst our respective sectors of our problem and solutions to them. As we've heard from Theo, the issues we face are global and affect huge numbers of people across all socio-economic groups and throughout the whole life course. We have a great set of data, as we've just seen, and I think there's a broad agreement within our respective communities on the policy agenda to be made. These things give us a solid foundation from which to build public and political support. And yet, despite this, eye health and rehabilitation have been neglected by international and national political leaders. They remain insufficiently prioritised, under-resourced, poorly integrated within national health systems. So we have to ask ourselves, why is this? And there are a number of reasons, but a few of them include, bluntly, a lack of awareness of the issues and the importance of the issues amongst political leaders. They don't know about the problems, a lack of incentivization to act, or maybe a lack of an understanding of the incentive to act. They can't see why or how to fix the problems. And finally, in the key contents of what I'd like to address today, a failure to fully mobilise and include the voices of lived experience advocates in our advocacy efforts. When I joined IPB, one of the first things that struck me was the lack of individual and community voices heard in the eye care sector. We had a cohesive community of active and determined organisations, particularly NGOs, working to advance eye care for all, but very little engagement with the community we were ultimately trying to serve. In my experience, mobilising individuals and communities at every stage of the advocacy process is critical to attracting sustained political support. For example, including individuals and communities at the outset forces us to frame issues in a way that is consumable by general populations and ultimately decision makers. We learn to speak the right language. In eye health, there's a tendency to presume knowledge, to overcomplicate, to get bogged down in the detail of our issues and the ideal solutions. Sometimes we forget to tell the real life stories that matter and which resonate with political leaders. Including individuals and communities enabled us to frame our messages in a much more clear, compelling and concise way. And issues moved off the page into real life. In eye health, we learn to frame advocacy positively, present the world as if it would look if we solved the problems, explain the opportunities and the potential for everyone. And it's the patients and the users who make the most powerful advocates, as we've seen today from Helena and Stephen. They inspire action. They are the ones who best articulate a compelling vision and mobilise people around it. This way of thinking has been critical, for example, to our advocacy success at the United Nations. Ambassador Webson, who is the first blind ambassador at the United Nations, has been at the forefront of pressing for the first UN resolution on vision, which we hope will be adopted next year. Mobilising individuals and patients raises awareness and creates an incentive for political action. I think today there is a recognition that top-down advocacy can only get you so far. We've seen this in eye health. Over the last 30 years, we've had several World Health Assembly resolutions adopted, action plans developed, and global eye care coalitions formed. And yet this has still not produced the resources at the scale and breadth required to meet the growing demand. Universal eye care, or the expansion of rehabilitation services, will only be achieved if there's sufficient public pressure for services to be delivered sustainably, so that governments are prompted, encouraged, cajoled to offer affordable, accessible and high quality services. Activating and empowering communities and individuals builds public and consumer demand for services, creates political demand for change, and improves understanding and promotes health-seeking behaviours around eye health and rehabilitation. I think the challenge in that is engaging large groups of individuals and communities in advocacy. And here there's no one size fits all, and we need to think quite creatively about how we best do that. I thought I would share with you 2 examples of where we have mobilised individuals and community voices within eye health advocacy. The first was in 2018, in the run-up to the 2018 Commonwealth Heads of Government meeting, or CHOGM. One of our members partnered with Global Citizen, which is a movement of 100 million people working to end extreme poverty by 2030. Through this partnership with Global Citizen, we held a huge event in London and were able to encourage thousands of people to send tweets to world leaders calling for a commitment and action on eye health. This mobilisation really complemented our traditional means of advocacy and engagement with member states and the Commonwealth Secretariat. And it resulted in a commitment at CHOGM to achieve quality eye care for all and to the elimination of trachoma. This was the first head of state commitment to eye health, so a real achievement, and wouldn't have been possible without that huge mobilisation effort made across and beyond the sector. My second example is our activity that IPB did this year for World Sight Day. The theme of this year's World Sight Day was Hope in Sight, which I think resonated with a lot of people, particularly this year for a number of reasons. Over 250 organisations directly supported and promoted the day across their social media channels and communications. We were able to mobilise a huge number of activists, particularly users. We also reached out and partnered with others beyond the eye health sector. We engaged corporates, for example, Kellogg's, a cereal brand, included our World Sight Day logo on their cereal packets. Some of our members also worked to publish a children's book on World Sight Day, which featured 35 well-known authors and illustrators from across the world on the importance of eye care for children. And this enabled us to engage teachers, parents, and children, a whole new audience for IAPB. World Sight Day was a huge awareness raising effort, which resulted in 40,000 tweets in just the UK alone, and more than 30,000 clicks on IAPB social media accounts. But we were also able to harness this momentum into political action. Off the back of all of this activity, we held a high-level event at the United Nations, where we formally announced our intention to pursue a UN resolution on vision. The voices we heard during World Sight Day made this possible. I'd just like to end with a couple of points. So firstly, when IAPB started this process, we didn't have a big base of individuals and communities with which to work. So we had to rely on working with partners who did. And this was useful because it really helped us build partnerships beyond the sector who could advocate for eye health. But now at IPB, we are starting to build our own base of advocates. We're also taking advantage of the fact that we're all increasingly living in a virtual world, which provides a much easier mechanism for us to engage more users and individuals. So all of this, we hope, will go a long way to providing a catalyst for change for eye care. Thank you.
Fantastic, Jessica. Thank you for also portraying some very visual examples of initiatives that IPB have conducted recently. One of the comments in the chat is, of course, everything is good, experience is important, research is important, but the crucial thing or the crucial thing is getting interest from decision makers. And at that point, you also portrayed the example of the great initiative during the World Sight Day. and also what has led to the request of a resolution for vision at the United Nations, what is really a great outcome and also political commitment. I see that there are more specific questions in the chat that perhaps can be answered more at the technical level. But I would like to go back again to our panelists, especially now to Stephen and Helena. So to hear from you also at this point, if you could think of rehabilitation and what WHO could do in order really to get more buy-in and advocacy and voices from people living with NCDs to advocate for rehabilitation, what you would advise?
I mean, from my perspective, I think it endorses some of what Jessica was saying towards the end of her talk, and one of the comments in the chat. It's very much about getting policymakers to listen, and the best way to get policymakers to listen is to actually get them to listen to lived experience stories, because I think they do really resonate with policymakers and make it into something real rather than just a piece of paper with a set of numbers on. But you need to repeatedly advocate. It's not something which happens as a one-off. You need to repeatedly advocate, you need to advocate from different perspectives, and you need to advocate in different settings. And you need to give people with lived experience the opportunity to be part of the WHO's work right from the very beginning, so that we really are working from the bottom up, not from the top down, or if you like, from the bottom up and the top down and meeting in the middle. But it's not paying lip service to advocacy. It's if you're putting a panel together to address rehabilitation and you're putting a high level panel together, that panel actually includes people with lived experience. It isn't something that then provides an output and gets an opinion from people with lived experience. That people with lived experience are embedded right from the word go in the WHO's work on rehabilitation. Some people from lower middle income countries who have experienced the difficulties of accessing rehabilitation, you know, Stephen doing great work trying to promote rehabilitation in Uganda. Someone like me being able to tell a story of how beneficial rehabilitation has been and what a tremendous difference it's made to my life, so that people actually hear that. So I think it is very much, I mean, I'm biased, obviously, but I think it is very much about having people with lived experience integrated into the whole process, not an add-on afterwards.
Stephen, do you want to add something to what Helena has said?
Yes, I think the need is there, but we need to work with people who have the need. I think I want to talk especially about the issue of demand creation, because policymakers will look for numbers, and sometimes there is a lot of stigma associated with the disabilities.
Yeah.
And people sort of coil back in their corners and don't say anything. We need to bring out these numbers. We need to tell them that, look, something can be done. And possibly voices like that of mine and Helen could help this person say, look, we saw you how you were, and we have seen you, like Helena is still going through rehabilitation, which certainly has helped her. When you meet her, you can't believe what she does and what she is, and yet she has quite a difficult situation. So these stories need to be only not heard by the policymakers, but also by the people with the need, rehabilitation needs. And these numbers then, because politicians especially, but all policymakers generally want numbers. When we bring out these numbers, like what Prof was sharing on the statistics, and we need to say that this is, and then what the difference to make if something was done. I think this is what we need to do and do it repeatedly. It may not happen overnight, but I think we need to keep at it. We need to keep raising the flag high, and hopefully somebody will hear us.
Yeah, thank you. Very well said. And actually, it is for us and it's the first time that we work with the coordinating mechanism for NCDs, and I really hope that it will not be the last one. Also for engaging with the stakeholders in the NCD arena for advocating for rehabilitation, because as I mentioned, also very often, if not people for with NCDs, who should advocate for rehabilitation. But let's turn again to Guy, and then to Theo briefly. Guy, please.
Yeah, thanks. Don't want to keep Theo from having the mic, but very quickly, I just want to come in on that and your call for broader collaboration with the GCM, but also for some of the comments heard from Helena and Jess and all the speakers actually. But it reminds me of, we've mentioned several times already because it's very fresh in our minds, the WHO consultation on people living with NCDs we had this week. And there was so much interesting discussion, and it was really trying to look at cross-programmatic also synergies and complementarities, not only in the NCDs, in the NCD agenda, but also looking at lessons learned in other programmatic areas and how they had really implemented and operationalized meaningful engagement. And all of what we said today brings back to mind some very interesting comments that I picked up from that. One of them was the repeated underscoring of the transformative power of connecting a strong narrative with very strong and impactful storytelling with evidence. The linking of storytelling and narrative with evidence, that is a very powerful tool that can get to the minds and the hearts of policymakers, not only the hearts, but the minds and the expertise and knowledge that they need to empower their decisions. It's a very strong, and we underestimate that. I think that's what we've all been saying. And both those pillars, the strong narrative and the evidence, has to be underpinned by lived experience. And then another very overarching generic comment, which I think is very relevant here, is that when we empower communities, we empower the entire system. So it really is, it's really having shedding some light on that community response, the community empowerment as a driving force, as that bottom-up force that will inform policies, programs, decisions at the policy. So we have to pay attention to that community response, empower at that level, and that will feed up and fertilize the rest of the system. So I think when you're talking about requests to WHO, I think as Helena put it very well, it is bring lived experience, bring that narrative, bring that into the discussions, to the discussion room, and to co-designing responses. I think WHO, we, the GCM, are committed to doing so. We can accompany you with that through this webinar, and also sharing this webinar, because it will be shared afterwards to go beyond those that are participating live today to our broader communities. Back to you.
Yeah, no, thank you, guys. So it's a great summary what you did at this point, referring to all the comments that has been done so far. Theo, could you share some experiences that you have experienced in your career at IHIME, where you have seen over time numbers changing the conversation? In terms of demand for services. You are on mute, Theo.
I think probably the best example there, and this is not just from my time at IHME or the more recent incarnations of the global burden of disease, but going back to the early 90s, when a few of us started quantifying population health using these comparable metrics, was that it was a great surprise to many people in public health how large the contribution of mental disorders was to the overall burden of disease. And someone very prominent in mental health ranked it as one of the most important contributions to global mental health. To a lesser extent, the same has happened in other areas that tend not to have people advocating, like musculoskeletal disorders, or maybe there's more advocacy, but very localized in a particular area, say for hearing loss and vision loss. As opposed to the very large diseases that get a lot of attention in global health, like HIV/AIDS and TB and malaria. And so what we have learned, and these are just a few examples, but what we've learned is that meticulously trying to document how large these problems are, how it varies between countries, how it changes over time, is very important, not just to do this for the major diseases that everyone has in their head, but also to look at things that people have not given a lot of attention to, but are considerable contributors to overall burden in populations.
Yeah, no, thank you, Theo. And Jess, any final comment from your side?
I think really to echo what's been said, I mean, one of the things that I would say is that, it really takes time to build, a huge number of voices in an advocacy effort. So, being prepared to sort of do the long slog or the long haul when it comes to your advocacy around a certain issue, and also being prepared to do much more around soft advocacy. So whilst we were able to utilize those experiences that people brought to World Sight Day or to our CHOGM activity, it was done in a much less indirect way, rather than sort of direct kind of lobbying that we would traditionally do with member states. So investing in that style of advocacy, I think, is really important.
Great.
Can I just make one final?
Of course, Helena.
Which is, I think it's also about empowering people to advocate. And I think this builds on what Stephen was saying about stigma. And that's often a reason that people don't want to advocate, because they feel stigmatized by their disease or disability and don't want to share it. But I think empowering people to advocate, giving them the tools to advocate well, providing training and support for people who are going to advocate as individuals with lived experience, I think is really important and needs to be built into the whole system.
Yeah, great, Helena. And I think with these words is a good way to end, because it is really about building voices, empowering people to advocate with the appropriate tool, with the appropriate evidence, what has been the narrative, and also the good coordination and the good engagement and collaboration from different stakeholders. So it has been really the message transmitted by all the speakers through this fascinating discussion. So from my side, thank you to everyone for being today with us, for really joining voices for collaboration. Helena and Stephen, we will come back to you in the future for sure to continue building that narrative and engaging those voices. And thank you again to everyone, also to Jessica and to Theo for joining us. And again, the coordinating mechanism for the collaboration. Thank you.
Thank you so much. And it's not a mistake. What you're seeing here is our next webinar, just inviting you to the next webinar in February of next year. But it's not that we made a mistake about the webinar. So thanks so much. I've learned so much, and it's been insightful. Thank you much, Alarcos, and all the speakers.